inviting me. In my title is complex, but I think the last speaker, that was a complex task. So for this task, it is now VSD morphology. And there are some complexities around the VSD. It can be as simple as in the picture, but I think, and that is what my feeling as a resident was, that the wording around VSD is adding complexity. Because we have so much also known as in all the mentioned areas where the VSD can be, this gets very confusing, especially in the beginning. And I also saw in the OR that closing the VSD is very simple wherever it is. So I think there is a lot of complexity around the classification and nomenclatation in VSD. And also it adds complexity that we look from different views. We look from echo view and from surgical view and from anatomic views, which is of course different. And so sometimes we must say it is complex to diagnose. Sometimes it is also complex to close, but easy to diagnose. This is also adding. I think the most relevant reason to have a complex VSD is other non-morphological factors or surrounding factors that make this patient a difficult patient and not the VSD itself. So let's go a little bit. I don't want to add more to the confusion about the nomenclature, the classification. We have this anatomic classification with mentioned VSD types. And clinically, which is also mentioned in the title, we have this VSD classification of subaortic, subpulmonary, and doubly committed, and non-committed VSDs, which can be muscular or inlet VSDs. This is, for me, the most clinical relevant classification. But in echo anatomy, this is all taken from available learning literature. They have sometimes other descriptions which we as surgeons also need to learn what the cardiologists are talking about and the other way around. So one way would be to print it. If you really have a problem defining where it is and if it is reachable from the tricuspid valve or is it possible to occlude, is to print it. It's now possible in most institutions. You have 3D printing technology available, and for, let's say, this is a posterior infarction VSD, but it can be also a congenital VSD. I think this is a meaningful and adding technology to visualize the holes, and especially if there are more than one, and if it is not clear where they are. So some considerations about our treatment options. In surgical closure, of course, we want to know if it is possible to reach it from the tricuspid valve, or if we need the PASS access. And also we have to know with a special type of VSD where the conduction system runs, which is different in the different types. If we have a non-committed or doubly committed VSD, we rarely get in trouble with the conduction system, while it is always there when we have a perimembranous VSD, and it's near in the inlet type. For interventional closures, we need other considerations. The surrounding structures and vascular access is more important for those eligible for repair. And of course, we have the other options, hybrid and bending, which have have been mentioned, so I don't want to go into much detail with it. But when I got the title, I thought of one baby that we had to repair when I was in the second year of my residency, where the surgeon was inspecting the heart and took 5 minutes to look inside and then decided, well, let's change. Let's close it again, do a banding and wait, which was a very good idea because it turned out that there are some other complexities around this baby that were unknown at the moment of the urgent operation. So this is, I think, a meaningful take-home message. So let's go into some of those mentioned in the title, the doubly committed VSD, with some particularities. The infundibular septum, where this is the normal situation and this is the diseased situation. We have, in normal situation, we have the pulmonary and aortic valve on different levels and the infundibular septum connecting those two. In a doubly committed VSD, a real doubly committed VSD, the infundibular septum is missing, which will make repair more demanding. That's why surgical results are maybe a little bit, or could be a little bit worse in terms of valvular outcome as compared to other type of VSDs. This is a very nice study of Doubly some years ago, where they had no AV block, and they had a long-term follow-up to look for what happened to the valves. And as can be shown here, the pre-operative aortic regurg status and the follow-up. So despite they manipulate on the valves, the aortic regurg gets better over time. But I must mention that there was one need for aortic valve replacement in this cohort. So some more modern techniques in treating doubly committed VSDs all come from Asia, and this is the main reason is because the doubly committed VSD is more frequent in Asia. It's like 40% of all VSDs in Asia are doubly committed VSDs. And I put it together for 4 of those publications and always mention the technical success rate, early or late aortic regurg, if it is mentioned. And of course, there was no severe adverse event in this Chinese publication. And it's all coming from China, relatively small numbers, but the technical success seems to improve. Whenever the technical success was not achieved, they mentioned that they took out the device and closed it surgically, and in no of the studies was any severe adverse event. So I think there is a selection bias in in these publications. It's publication bias, and we would not recommend to go this way. On the other hand, I saw Dr. Heinemann this morning. I'm also editor of one surgical journal. I must also say that the publications from China are dramatically improving, and the acceptance rate for those manuscripts are also improving, but I don't think we can really say that this is a technique that we want to pursue. Okay, let's go to Swiss cheese. Some words on Swiss cheese. This is the right ventricular view. It's from a Dorf patient with multiple muscular VSDs from the right side and from the left side. You might automatically see that it would be very nice to close it from the left side, but you obviously have to open the left ventricle. When you try to find evidence what people did with Swiss cheese or multiple muscular VSDs, there's very few data on it. This is a group that has collected from patients from 2 institutions and got 17 where they all did the pulmonary banding. And what I found very interesting, during the follow-up, and they left the banding very long, all muscular VSDs in the patients where they did not close the principal VSD, all spontaneous closed. But there is also data from, this is from the Indian group that was also mentioned before, where surgical technique is a little bit modified, and it is possible to close it with a transatrial approach. So it is possible to close it without major residual shunts. In an older series, this is also patients over a long period of time from the 90s, they mentioned that the approach through the LV in those patients is a good one and results in very good VSD control. So in very anomalous situations, this can also be one of our approaches. In younger times, this is from St. Augustine, interventional closure of VSDs is also possible if this is, of course, a very selective group of patients where maybe surgical approach was not possible or risky, and they had in most patients a significant shunt reduction by closing the principal VSDs. So I want to finish with one case where, in muscular VSDs, we we often go this way in a hybrid fashion. We identify the best spot for introduction of the device. This is a hybrid approach. So with a finger, we can identify the best spot and then enter the right ventricular wall. You might see that it is, for us surgeons, not the best place in the, but it was very easy to pass the VSD and then pass over the first wire, pass the sheath through the VSD. This will now be visible. So it's somehow coming from the apex, but it is very important to not proceed with the sheath further, because you can damage the posterior wall. It happens. So there's always one hand holding this straight, and the interventionalist can then proceed with in this case, Amplatzer occluder. Okay, I think now it is visible on the, we changed to echo. By the way, thank you, Johanna, for this nice recording. So this is now easy to close. You can loosen the device and finish the procedure right away. So I think this is doable, and one way of dealing with combination of complex morphology can be done. So we prefer full stenotomy for these cases to select the best place, because having the best place is important to get the wire straight through, and then you will end up with a good result and a happy team and a good patient. So, when I want to conclude on complex VSDs, I want to say that we have a lack of rigor data on this topic. For my feeling, a clear communication about the VSD and in the same words is important. And the more difficult the patient or the morphology is, the more multimodal diagnosis and treatment is needed. So it's a bit of a, we say, Plattitüde in German, but it's true. And a combination of tools might also be optimal. Thank you.